Good afternoon. My name is Dr. Randy Jernasik, and I'm a physician at the University Hospitals in Cleveland, Ohio. I'm here to help moderate a panel of excellent physicians who will talk today about the Northeast Ohio Opioid Consortium. The consortium is an innovative and unique group of healthcare leaders representing all the healthcare systems in Northeast Ohio and working together collaboratively to address the epidemic in our region. While normally competitors in a region where competition can be strong, the work they have accomplished together is even more remarkable. Today, they will share some of their stories. They hope to share their work and inspire you to take some of what they have done to your home. The members here are always open to help and consult as you need. While there are many consortia focused on opioids, this is the first and only that we are aware of that is made up of all the healthcare systems in the regional area. It is physician-led organization with physician members from each of the following sponsoring institutions, which you will hear from today. University Hospitals of Cleveland, my home institution, the Cleveland Clinic Foundation, the Veterans Administration of Cleveland, Metro Health, St Vincent Charity Hospital, as well as the local Academy of Medicine. We are housed as a consortium under the Centers of Health Affairs, which is the nation's first regional hospital association founded over 100 years ago. The consortium was started as an outgrowth of work done by the Northeast Ohio District Attorney and the Heroin Task Force she founded approximately 5 years ago, and was guided by the leadership of the CEOs of our founding hospitals through their wisdom and foresight to come together to help fight the epidemic that was growing in our community. Together, they saw the need for the leadership that only healthcare institutions can bring to this cause. The consortium came together a little over 3 years ago, and I'm proud to have served as the inaugural chair. Having me here today as the moderator of this excellent group of physicians makes me proud to see the work that they have done. While I am the moderator, the people that you will hear from today are truly the physician leaders that are driving us ahead and making the magic through the work the consortium does every day. While I said this is a physician-led organization, let's please be clear, they are not only physician-focused. You will hear about work they are doing together to share best practices, develop new initiatives, and support each other on innovative approaches to impact how healthcare is given across Northeast Ohio. They have nursing, pharmacy experts on their team, as well as operational and legislative affairs representatives on the council to help with all aspects and dimensions of the work they do. Their impact is immeasurable, and now I'm going to ask them to share their work by starting off to talk about some innovative work that each of them do in their respective areas. And with that, I'm going to start with Dr. Joan Papp from Metro Health. Joan, please.
Thank you so much, Randy. It's a pleasure to be here, and thank you all for joining us today. My name is Joan Papp, and I am an emergency physician by training and a medical director of our region's first Office of Opioid Safety. At Metro Health, we really began our journey back in 2013 with a need to fill a gap and to help to really address the growing opioid crisis of overdose fatalities that we were seeing in our community. We were struggling with what started as a prescription painkiller crisis that had developed into a heroin and now currently a fentanyl overdose crisis. And as an emergency physician, the most natural and comfortable initiative that I felt was needed was naloxone, a drug that we're very comfortable with in the emergency department, and that we saw a need for expansion. And so back in 2013, we reached out to our Ohio Department of Health and collaborated with them to develop Project Dawn. Project Dawn stands for Deaths Avoided with Naloxone, and it is initially, it started out as a community-based naloxone overdose education and prevention training program. We started with 2 naloxone distribution sites and have grown into truly a hospital-based integrated system of naloxone distribution. We have currently 5 community naloxone distribution sites. that are walk-in sites where we offer free naloxone to members of the community and their family members. We distribute naloxone from the emergency department, and we distribute naloxone on the inpatient unit. And now, over the course of the several years that we've been running this program, legislation's been passed that now allows us to distribute through the pharmacies without a prescription as well. And so that has been one of the areas where we've really been able to collaborate. In addition to the Project Dawn program, where we provide naloxone, take-home naloxone to individuals who are directly at risk for opioid overdose, we also have a co-prescribing program. And I think that will actually serves as a good segue to our next area of innovation, which is our electronic health record initiatives. With our electronic health record initiative, we've been able to more easily co-prescribe naloxone with alerts that raise awareness for providers who are prescribing an opioid to also co-prescribe naloxone. In our electronic health record, we have hardwired not only naloxone co-prescribing alerts, but other best practices for safe opioid prescribing and for MAT prescribing, as well as some tools to track progress, including an opioid dashboard and an MAT dashboard. Some of the tools that we have initiated include things like inline MED calculators, so that individuals who are writing a prescription have that knowledge at the time of prescribing exactly the amount and the potency of those prescription opioids. We've also been able to integrate our PDMP so that you can access the prescription database monitoring platform with a single sign-on and a single click, making that information available at the fingertips of prescribers when they are at point of care, taking care of patients, writing a prescription for an opioid, or evaluating them for medication-assisted treatment. We've also developed opioid registries and an opioid dashboard that allows physicians to have real-time access to their prescribing data metrics, and allows them to not only see their prescribing patterns on a daily basis, but it also allows them to track their progress over time. You know, are these initiatives working? Are there attempts to cut back on prescribing working? And they can see and track their progress over time. Our opioid dashboard also allows prescribers to track their medication-assisted treatment patients. This is a very robust dashboard that allows providers to see not only which patients they have on medication-assisted treatment with either buprenorphine or naltrexone, but it allows them to track those metrics that define quality care. How many patients do they have? Are they monitoring their toxicology screens? Are they checking their HIV and hepatitis status? They checking pregnancy tests. You know, all of those stewardship monitors are tracked in our dashboard, and that has been a great success.
Thank you, Dr. Papp. Where I think we're going to talk a little bit about how we're sharing that, but we're going to ask Dr. Stream, who's our current chair of the consortium, to talk a little bit about some of the innovative work that they're doing. David? You're on mute.
Thanks, Randy.
On mute. There you go.
Yeah, there we go. So many of you know that the relationship between endocarditis and substance use disorder is new. As a medical student and psychiatry resident at Cleveland Clinic in '94, I remember seeing consults on the cardiology services with this condition. But many of you probably know that the substance misused by the individuals I saw around that time was far more likely to be cocaine, IV cocaine. Many of the same problems we see now were grappled with then, especially poor follow-up with substance use disorder treatment after having had major valve replacement surgery that then required weeks of IV antibiotics. As the opiate epidemic spun out of control in the late 1990s, early 2000s, the demand for endocarditis treatment coming both inside and outside the state of Ohio began to rise, and the percentage of endocarditis patients with co-occurring opiate use disorder also rose. As documented by the Mayo Clinic and others, these courses of treatment can cost well over $100,000 and often lead to questionable benefits to the overall health and quality of life of the patient. In these cases, the absence of facilities that can provide critical illness recovery services, COPAD, and SUD treatment services played a major role in the failure to achieve treatment goals and prevent readmission and endocarditis recurrence. Around the same time, the Cleveland Clinic entered into a joint venture with Select Medical, which is a provider of critical illness recovery and LTAC services in several states. The agreement permitted us to be more involved as Cleveland Clinic caregivers, and particularly OUD treatment providers, as patients moved across the levels of care. So the interdisciplinary care team we had struggled to establish and sustain for more than a single case, suddenly demonstrated the ability to engage with patients as a unified service line. And this required the participation and collaboration of the cardiothoracic surgery group, infectious disease department, consultation liaison psychiatry, and my group, the Alcohol and Drug Recovery Center. Equally critical has been care managers working in hospital and LTAC settings. Patients who were referred for the service line were engaged in OUD treatment, including buprenorphine treatment as soon as possible. Other serious infections like osteomyelitis and septic arthritis were also included, as these infections present similar challenges. We were also able to better engage family and social supports to ensure patients remained or encourage patients to remain adherent with the treatment plan. So once operational stability and scalability of the service line was established, we have then moved into tracking patients and measuring outcomes. This has been somewhat challenged by initial resistance coming from payers to specifically agree to services provided at this one facility where the SUD treatment team provided services versus other in-network providers that did not have that capability. All patients have SUD treatment arranged at discharge from Select Medical, either as residential treatment or outpatient. Treatment providers who provide evidence-based treatment are always very strongly encouraged. Since some patients moved to treatment centers outside of the local area and sometimes even out of state, we've considered various criteria for the success of the service line. Of course, survival has been the most important. We also attempt to track patients who fill at least one prescription for an OUD medication by a non-service line prescriber within a month after discharge. So that implies that they're continuing to do the other things that we know are important for treatment adherence. And we know the longer that patients remain in treatment, the more likely that the treatment is to be effective and translate into long-term remission of substance misuse. So using the latter as an indicator, we were able to determine that around 50% of our service line participants had a successful outcome, which is much improved from most of the case series that you'll see published in this area. So we're engaged in a wider effort to track outcomes and associate those outcomes with possible predictors like the microorganism identified, discharge destination, or if they have a history of chronic pain problems. And we're hoping to report significant findings as a result of this effort. And we've already shared news of our progress with our partner hospitals in the consortium. Speaking of which, the development at Metro Health, as you just heard from Dr. Papp, of a best practice alert regarding naloxone co-prescribing was great news that we began to work to adopt as soon as it was announced. Since Metro Health and Cleveland Clinic used the same electronic health record system, it was relatively straightforward to implement a very similar best practice alert in our organization. And just as had been the case with the Metro experience, The BPA activation prompted a huge increase in naloxone co-prescribing when opiates are prescribed. And while implementing this tool in my organization, we learned a few things that we shared back with our colleagues at Metro Health. First, the prevention of repeated prescribing of naloxone requiring the establishment of an estimated expiry date for the BPA. Second, education to the patients as to what the purpose of the naloxone prescription was important to improve prescription acceptance. Finally, I just want to mention how happy and proud I am that we're working with medical student, graduate medical education, and continuing medical education programs, so medical schools, residencies, and CME around the region to provide inpatient and outpatient SUD treatment experiences to trainees and Data 2000 waiver training and follow-up CME training to support the development and maintenance of a regional SUD diagnosis and treatment workforce. And that's something that all of us have, as a group, have been working on together. Thanks.
Thank you, Dr. Stream. Excellent work, and I love not only the innovation, but the sharing with Dr. Papp there. I know there's also been some innovation in sharing Dr. Jean Lecamp at University Hospitals.
Phew.
Hi, thanks, Randy. I am so thrilled to be with everybody today. I can't even tell you. We have been planning this for so long, and it's really, truly a pleasure to be able to present even just a small amount of what the consortium has done as part of this conference. As a leading academic medical center in Cleveland, UH has a long history of teaching and learning, and I really can't tell you how powerful it is to learn and share with colleagues that you're seeing here today. So if any of you are feeling energized or invigorated by what you're hearing, imagine being in these meetings all the time. I mean, it's really tremendous, and the amount of information that is shared is just terrific. So there are really two and a half maybe innovations that I wanted to share today. First off, UH has created a multidisciplinary system-wide pain management institute. And the reason for that is really, as was mentioned by Dr. Papp earlier, if we take a step back to the prescription medications that really fed into the opioid crisis, I think we identified that we needed not only to address opioids, but we needed to take a step back. If over 50% of people who are, having opioid use disorder really started by using prescription opioids, we really knew that something better had to be done for pain management. So the UH Pain Management Institute was created a couple of years ago now, and this institute incorporates elements of not only pain management, including alternative and complementary treatments that you're going to be able to hear a little bit more about in another one of our sessions. Also incorporates behavioral health providers, addiction treatment providers, and a strong focus on education. The goal of the Institute is to maximize function and minimize risk. And so you don't hear eliminate pain or even eliminate opioids. We are really prioritizing that we want patients to be able to function to the best of their ability. We have really prioritized education for our providers, including the consortium portal, education portal, but also our toolkit for education for our own providers and our own staff. And to Dr. Stream's point from earlier, really educating patients as well. There's no use educating all of our providers if we aren't having a trickle-down effect to educate our patients. So we participate in system-wide family health and safety days. We have launched many initiatives to get the word out to our patients. And then also for an innovation for patient care, we have last month launched a multidisciplinary comprehensive pain center at one of our community hospitals. And this has participants from pain management, PM&R, physical therapy, behavioral health, addiction services as well, and Connor Integrative Health Network. And we are so thrilled that we are starting this and hopefully rolling it out across the system. And then, I really feel like COVID-19 has been a brutal teacher. We were not innovative in wanting to include peer support. to our patients, but we were very innovative in how we got this accomplished. The Thrive Peer Support Network has been involved in various systems around our region, and Dr. Papp was innovative in that as well. But when we had COVID-19 come to call, we realized that we didn't want to have additional visitors and additional personnel in our emergency departments for, patient safety and infection prevention. So we were able to pivot very quickly to have a virtual experience with our Thrive Peer Navigators. So I think that was an amazing opportunity for us that we didn't necessarily welcome based on COVID-19, but we were very happy to pivot and work with our colleagues there. And then I think Dr. Ted Perrin is going to be talking a little bit about the innovation that UH in conjunction with St. Vincent's had, to Dr. Strain's point regarding some of the brand new training initiatives so that we can train more addiction providers in order to best serve our patients.
Thank you, Jean. Excellent. I appreciate you sharing. Next, we're going to ask Dr. Kevin Smith of the Cleveland Veterans Administration Hospital to share some of the great work that they're doing and the interactions we've had together. Kevin? And you're on mute.
Sorry for that. I appreciate the opportunity to be able to speak on behalf of the VA. In 2015, in the throes of the opioid epidemic, the VA, which in Cleveland, which covers 100,000 veterans in the upper northeast quadrant of Ohio, was only treating about 100 vets with medication-assisted treatment. So at that time, we started an ambitious Suboxone expansion project. Fast forward 4 years later, in 2019, and we were treating more than 400 veterans using an office-based opioid treatment expansion project. More importantly, is we were able to increase access. Some of our vets were traveling 2 to 2.5 hours to get to the main medical center in Cleveland. We were able to provide Suboxone at all of our community-based outpatient clinics as far away as East Liverpool, Sandusky, and Mansfield. As we increased our MAT expansion, we started looking for the newest MAT that was available. And so we started to explore the option of going to Sublocade, the injectable Suboxone. So in July of 2019, we got permission to begin exploring how we would do this. We were able to get risk evaluation and mitigation strategy clearance through our VA pharmacy. We were able to get our nursing staff injection training. All of the nurses that we used did have subcutaneous injection experience. And we were permitted to go to 10 for the first year, partly because of the extremely high cost for Sublocade. So during the past year, we have treated 20 patients with Sublocade, and 16 of them have done very well. Only 4 have dropped out. The cost-benefit analysis of looking at Sublocade versus Suboxone is actually being explored nationally by the Veterans Health Administration, and the Cleveland VA has joined that research study that's going to look at the effect of Sublocade versus Suboxone using sublingual strips. One of the issues that we've had to deal with during our Sublocade project is the concern with infections. And actually, only one of the 2 cases of infection that we've had were something related to the actual infection site. The other one was caused because of the patient's inappropriately picking at the injection site. We have gotten permission from RVA to expand to 30 by the end of 2020. We probably will not be able to meet that due to COVID-19. And then next year we'll be able to go to 40. Our goal eventually is to be able to induct people at the medical center and then have Sublocade available at all of our large clinics, which is 4 of the 12 that we have in our geographic catchment area. Speaking of COVID-19, later on during this presentation, I will talk about our VA telehealth initiative, which was a best practice that has been shared with the consortium. Randy?
Great. Thank you, Kevin, for all you do, and excellent presentation. I'm going to ask Dr. Ted Perrin to speak about the excellent work that they're doing at St. Vincent Charity Hospital. It's always been a leader in addiction services and substance use or disorder throughout the community for many years. Ted?
Well, thanks, Randy. Let me emphasize right at the beginning before talking about St. Vincent Charity. You know, as an internal medicine and an addiction medicine doctor here in Northeast Ohio for the last 32 years, and I've either been on the medical staff or taught at every single one of the institutions represented in this consortium. It's a remarkable thing to have this outstanding group of clinicians working together to approach in different ways, but in complementary ways to approach the opiate crisis here in Northeast Ohio. At St. Vincent Charity Medical Center, as Randy said, has been a leader in the management of substance use disorders in Northeast Ohio since the early 1950s, and opiate use disorder in particular since the late 1980s. Through its treatment program named Rosary Hall. More recently, in response to this opioid epidemic, and in close collaboration with the other hospitals, St. Vincent Charity Medical Center has done the following things. They've expanded the acute detoxification capacity from 12 beds to 27 beds at both a 4.0 and a 3.7 level of care. They've doubled their intensive outpatient program capacity from 20 to 40 patients. St. Vincent Charity started a partial hospital program level of care specifically to try to meet the needs of patients who were being started on MAT and then dropping out of treatment. And they also started the first MAT-specific intensive outpatient program in Northeast Ohio. In sort of conjunction with and mirroring the VA, St. Vincent Charity has markedly expanded treatment with sublingual buprenorphine, injectable buprenorphine, and injectable naltrexone. St. Vincent Charity has also reached out to the methadone programs in the region, which have been long established community-supported agencies, but also often were lacking some of the levels of sophistication in counseling. And so St. Vincent Charity was the first treatment program to open its PHP program and its IOP programs to patients who were enrolled in methadone maintenance programs, but needed a higher level of care for the substance use disorder from a counseling standpoint. With all of this expansion of treatment, one of the biggest challenges that we were faced with was patients who weren't completing PHP and IOP levels of care. And as we all know, completion of an IOP level of care is one of the single best predictors of longitudinal sobriety. And received a grant from the Sisters of Charity Foundation and several philanthropists in the area to pilot a unique rideshare program for people involved in outpatient counseling. And we've nearly doubled the completion rate of PHP and IOP with that rideshare program. Finally, St. Vincent Charity and university hospitals have collaborated since 1990 for 30 years, running first a joint addiction fellowship training program, and then two collaborating addiction fellowship programs, addiction medicine at St. Vincent Charity and addiction psychiatry at UH. Because of this 30-year track record, we were the only interinstitutional applicant for the recent competitive national HRSA grants. And university hospitals at Cleveland and St. Vincent Charity Medical Center were jointly funded by HRSA to double our fellowship training capacity over the next 5 years, from 4 fellows trained per year to 8 fellows trained per year between our two programs. And we consider that sort of a gemstone, if you will, of interinstitutional collaboration over time.
Thank you, Ted. Appreciate an excellent review. We're going to be running a little bit closer on time here, and we want to make sure Dr. Tom Collins has time here at the end to pull it all together. But we're going to do a very, very brief, quick round robin about some sharing. You've heard a little bit about it. This talk is about innovation and sharing with each other. And so, Joan, just a very brief kind of something that you're excited about that you've either shared or been able to get from one of the members, please. And you're on mute.
Of course, that's like the refrain from 2020. You're on mute. So, I think probably the best example of a project that we've shared has been our naloxone program. That was one of the things that we had the most experience with, and one of the things that the Center for Health Affairs really helped to coordinate on the sharing end. They brought together pharmacists from all the institutions to share protocols, policies, did a institution-wide, system-wide survey to find out what our needs were, and then helped to contribute to a toolkit, which is posted on the Center for Health Affairs website, which is just phenomenal. It's public facing and has resources for providers, for patients, for pharmacists, really for anyone who is interested in any aspect of getting naloxone out in their practice environment.
Great. Thank you, Joe. Appreciate it. Jean, what would you like to highlight about the sharing?
Well, it's great that Joan was just mentioning a toolkit. Certainly, I think the Consortium education portal has been crucial for university hospitals. Our nurses have utilized the portal. I think roughly 3,000 nurses from UH have utilized the portal over the course of the past year. And that's huge. They're not only getting education clinically, but also we are bringing this to the forefront and allowing opioids to be discussed, making sure that people are learning how to care for and about patients with opioid use disorder. So I think that's been huge. And a small shout out to the Narcan alerts that we are also building in, but we have a different EMR, so it was a little challenging, but we took a lot of lessons and a lot of guidance with much appreciation from our colleagues.
Jean mentioned something. I said in my opening statement that this was physician-led but not physician-focused. One of the first topics we recognized across the community was we speak a lot about prescribers, but not necessarily enough about nursing staff who manages patients on the front end, no matter where they are. And one of the first topics that this team dove into was actually what Gina just mentioned, across the citywide educational platform for our nursing colleagues. And so really proud of that team. Kevin, brief, what you're excited about sharing? Mute. Kevin, you're on mute.
Yes, 2 for 2, sorry about that. The VA telehealth initiative from October of 19 to March of 20, we had about 350 telehealth appointments, primarily for those who live geographically at large distances from the VA. Starting in March of 20, the VA mandated a shift to all telehealth. So in March, we did 2,250 telehealth appointments, and since that time, we've averaged more than 4,000 a month. It was our privilege back in April then to do a presentation with all of our consortium members to give them information about our telehealth initiative, how we did it, and our successes, which we felt with COVID-19 was something that was going to be very pertinent both now and potentially moving forward in the future.
Wonderful. Thank you, Kevin. Ted, some sharing?
I would emphasize the educational components from a sharing standpoint. We were able to move from one addiction medicine fellowship, as I said, in 1990, to an addiction psychiatry and addiction medicine fellowship at UH and the St Vincent Charity in 2000. Just recently, in the last 2 years, we were able to consult with our colleagues at Metro Health, who were preparing to launch an addiction medicine fellowship program, and not only help them with their application and with core faculty, but also with interdisciplinary rotations between our different institutions. And so now our addiction medicine, our addiction psychiatry fellows rotate between university hospitals, the Cleveland VA, Metro Health Medical Center, and St. Vincent Charity Medical Center, taking advantage of the strengths of each different institution's clinical educational programming.
Thank you, Ted. We're going to ask Dr. Tom Collins from the Academy of Medicine to bring some of this all together. But I want to say one of the things that I think none of you mentioned about the sharing, but is obvious on today's panel, is watching the excitement, the interest and the enthusiasm you each have to work with each other. And I've watched it in the meetings, how you continue to move each other on and help each other and really set a tone for how we work well. And I say that because it's very important, but also because Dr. Collins also always reminds me that even though we're competitive, we all came together many, many, many years ago to work on vaccines as a city. And we can continue to do this and continue to work on other things besides just opioids. So Tom, I tried to set you up perfectly there.
Oh, Randy, you did a great job, and I should just say thank you and close the session. So the Academy of Medicine of Cleveland and Northern Ohio has been around for almost 200 years, and its purpose was to bring physicians together. Physicians were independent practitioners at hospitals. They were not employed medical staff until the more recent history. And so it helped organize the common enemies that we as physicians would have to fight. One of the things that's been incredibly heartwarming to see is this epidemic of substance abuse and opioid addiction and overdose has naturally brought these physicians from very busy practices all over town in a hyper-competitive healthcare market together at the table to support each other, as Randy said, work together. The Academy helps this effort through a lot of advocacy with our state and federal partners and regulatory agencies, whether it's working on recognizing alternative treatments, getting the mental health confidentiality rules to align with HIPAA confidentiality rules, or helping with how physicians are viewed and allowed to practice pain management. But it really is an exciting time, even though this is a horrible, horrible problem, to see such talented people come together to support each other. And it's, as Randy said, when the groups are getting together and we're having these meetings, everybody is working to help everybody be better at their own practice. I'll share my favorite quote that some of you know from Dr. Joan, who developed the polio vaccine. The greatest reward for doing is the opportunity to do more. And this group, time after time, demonstrates how they do more for each other and do more for the community. And it's really, really proud to be able to work with them. Randy, back to you.
Thanks, Tom, for bringing it all together and all you do. Well, we have about a minute left, 2-minute warning maybe in the NFL. Anybody with last parting words? David, you're the chair.
Well, I think Randy, you said it really well, that it's a group of folks who understand how important and how devastating the opiate epidemic has been, and that we all have a role. We all have our strengths and areas that are our wheelhouses, and I think everyone has. We've tried to be definitely a very an organization that plays to our own organization's strengths, and to the extent that we've been able to share that, as I think Tom put very well, that's a blessing that we all have to be able to share what we've done and what's worked, and other people have. Other organizations, other systems have been able to benefit from that. So that's been tremendous and very enriching and satisfying.
Thank you. Well, I know that every member on the consortium here are willing to not only help each other, but to help you in what you're trying to do. They certainly commented on the educational opportunities that are on the website, the naloxone opportunities are on the website for the consortium. You can find our consortium simply Googling us, or we can get that information to you. But the goal is that we do not create things to keep it closed into the folks that you see here on the screen today, but to be able to impact what we do in Northeastern Ohio and beyond by sharing. And we're happy to share whatever we can with anybody who can benefit from it. And so we appreciate your time today. And more importantly, I am with extreme gratitude for each of the people on today that you heard from. They are doing amazing work and are an inspiration to me and what I do every day. Thank you.
Good morning or afternoon to everybody. I want to welcome everyone to the All Hands on Deck session. My name is Carmen Nevadas, and I direct the National Overdose Prevention Network, or NOPIN, at Public Health Institute. Let me start by thanking Dr. Berwick for his presentation that helps to set the stage for understanding what impacts health and how we can reflect upon what is necessary to do this work. I'd like to start the session with a short check into what's happening right now, right around us. Today, the front page of the San Francisco Chronicle reported the tragic story of a mentally ill woman who lived on the streets, was well known in her community, and too sick to seek treatment. Mary Elaine Botts was found dead of an overdose on the street on November 18th. Numbers in San Francisco, as in many communities that we all serve, are grim. 563 dead in 10 months from overdose, with 164 dead from COVID. This is a complicated time, a twindemic, with both COVID and overdose as causes of death, both preventable. There's also some brighter news to share. Today, Ohio Senator Rob Portman is announcing a revamp of the Comprehensive Addiction and Recovery Act 2.0. This act would extend telehealth for medically assisted treatment, prohibit states from requiring prior authorization for MAT under Medicaid, provide housing for people with substance use disorder, and increase support for addiction treatment in correctional facilities, amongst other things. Both of these stories illustrate what we know about preventing overdose deaths. The successful prevention of death requires a broad understanding of what supports us to be healthy and collaboration of housing, healthcare, justice systems, and other partners whose work can help to improve the chances for people like Mary Elaine Botts. But we need to learn how to work together. So I'm very excited to have a wonderful panel to talk about what inspires their work with people whose lives have been impacted by substance use, and what we can learn about partnerships, and why this is important for effective work in this area. In our work at NOPN, we learn and relearn that problem substance use is rooted in complex origins, and that no one sector or profession alone is enough to help people who are ready to find their solution and sustain their success. We see this as an all hands on deck situation, and hope that in this session, we can draw on the experiences from this talented panel and think about how to make our work even more effective, working with others who are also dedicated to ending overdose deaths. I'm delighted to introduce Alyssa Takeda, a physician internist from Asian Health Services in Oakland Community Health Center, Gary Cox, an attorney who has served as a local health director in Oklahoma City, Oklahoma State Health Commissioner, and currently professor of public health at University of Oklahoma, and Cindy Cipriani, Assistant U.S. Attorney with the Office of the U.S. Attorney, Southern District of California. Welcome to all of you. I'm going to ask several questions of the panelists, and I ask that the audience also submit their questions and comments through the Q&A feature on your screen. The first question, Alyssa, let's start with you. What in your life experience drew you to want to help people whose lives were impacted by drug abuse?
Thank you, Carmen. So I am a Bay Area native. I grew up in Richmond, and a child of a single mother who suffered with use disorder. I wouldn't say that initially pushed me to want to help other people with substance use disorder, but just sort of that background really made me want to help people just within the demographic generally, the low incomes population. And she also had a genetic disease, Huntington's disease, a progressive neurological disorder that was really challenging. And so sort of facing those challenges in my personal life really sort of prepped me for digging deep into other people's lives who have other hardships. And so that's sort of the stories and the resilience drew me to that population.
Thank you. That's a very moving story. Thank you for sharing that. Gary, would you like to take that same question?
Sure. Thank you. Well, growing up in rural Oklahoma, there was a lot of poverty, a lot of people that had a lot of needs. And so, but I also noticed that not only did they have needs, but it was a tight-knit group. And so the community was tight-knit, even though it was perhaps poor, they would come together and help each other out. And so, eventually got into public health, and in public health, we were looking after as opposed to a physician, a one-on-one looking after the community and trying to work with the community. And so basically, I think most folks that get in public health do so because they want to help people. You know, they understand no one left behind. And so we've always tried to recognize the needs of others and tried to live a life of service to others. And I think that's very fulfilling, and it's going to take working together to improve the lives of many folks throughout Oklahoma and in the United States.
Thank you, Gary. Cindy, would you like to tell us your story?
So, as the first speaker indicated, you know, I think that my story is very personal. I lost a 20-year marriage to opioid addiction, and this is a person who was the president of the Stock and Bond Club, was a Little League coach, was very active in his community, was very successful as a broker, and basically was, I think, a poster child for what was happening in the 90s, where he had a pain condition, back pain condition, from an arthritis that he suffered in his 40s, and was given by his primary care doctor, who was trying to be compassionate in an era when they were basically being told, you know, pain is another vital sign. You need to make sure that you're addressing pain. He was given many, many, many scripts of Oxy and became addicted. And for a long time, I wasn't even aware of the problem. And I think that once I became aware of it and realized just how serious it was, I wish I'd known then what I know now, but ultimately I wasn't able to reverse it. And I realized that this is an epidemic that doesn't spare anyone. It doesn't matter what your income level, your success level, your demographic position in life, whether you're educated, not educated, rich, poor, in the middle. This epidemic affects everybody. And I think that I suffered through this silently for so long. And I think one encouraging aspect of how open the problem is now is that people can come forward. And I think we're all working together to reduce the shame and reduce the stigma, and to be open about the fact that this is a health problem. It's not a discipline issue. It's not a willpower issue. I didn't realize at the time I was going through this that I would ever have an opportunity to impact the problem. But when that opportunity did present itself, it was incredibly meaningful and cathartic for me to be able to participate.
Thank you, Cindy. These are really very important stories. And I think what I'm hearing here is that many of us grow up in, thinking that our situations are our own, our situations are personal, that we should keep silent about them. And we're hoping that one of the things that we hear and have rededicated ourselves to by the end of this meeting is that we need to break the silence on this issue. We really need to find the ways to share our stories in as personal a way as possible, as we're able to be comfortable about. I think that the opportunity to be part of this panel is really one of those times where we can be very frank about what has brought us to this work. And I think that in the answer to the next couple of questions, we'll get even more personal with all of you about what motivates you. I think the other point brought up here, I think very clearly by Dr. Cox, is the idea around community and how we need to think about our communities supporting each other in this work, and think about ways in which our community can be a real lifeline. That maybe by ourselves we're not as powerful as we might like to be, but that in wrapping ourselves with our community members who might be open to listening and might be open to helping, that can be a real opportunity to also try to move forward, break the silence, and move towards a way to reach people that really need to be reached. Let me go to the second question, which is going to really take us more into how you have found your work and how your work has inspired you to think about what you're doing. So how has your unique professional background helped you to understand the problem of substance use disorder in a different way, and to understand why partnerships are really so very, very critical. So let me start this time, Gary, with you. Would you like
Sure.
to take that?
Sure. Well, yes, in public health, I can just give an example here in Oklahoma City. The problem was, and the problem was overcrowding of our jail system here, and the fact that it was estimated about 70% of the people that were in the criminal justice system were either there for drugs, alcohol, or for mental health issues, and that's just not the best place for them, and they're low-level offenders, and they're nonviolent. And so the community realized this and came together here in Oklahoma City, and it was a broad group of folks, all the way from prosecutors and public defenders to nonprofits, faith-based organizations, community-based organizations, philanthropy, and many others came together, around 40 people, and decided to try to do something about this. And so got a couple of national grants to get it all started. Public health was the convener in this situation. And actually we surveyed some of the population of the jails and found out some very interesting things in that survey about why people are coming back into the system. And one of the reasons is, if you really look at the social determinants of health, it revolved around housing. If they didn't have a house, a safe place, then it's likely that they would end up back again. And so we started focusing, we hired some community health workers to work in the drug court and to work with many folks. They were very effective because they looked like the people that they were serving. And they actually linked them to services. As a result of that, there was a sales tax that was passed here in Oklahoma City, and a diversion hub is being built, $11 million. And then it's a public-private partnership because as a condition of this, the private sector had to raise $20 million for operations. And so there was money in there, $50 million for housing, and 2 restoration centers for mental health centers and substance abuse centers. And so this is a power partnership. So the community coming together, realizing that you have some real serious challenges in your community, private, public, coming together and saying, we're going to do something about it. And so it's been very effective and helped a lot of people.
Thank you. That's a truly excellent example of that broad group of people that are necessary to speak to the topic and really start to roll up their sleeves and get involved as a group. Cindy, would you like to take that question? What have you learned in your professional? How's your professional background inspired you to do what you're doing?
So I think once upon a time, you would see U.S. attorneys at major press conferences announcing fraud or cartel indictments, and you didn't really see U.S. attorneys and people from the Department of Justice out in the community. And that really did change 10 years ago. And we were directed, don't just file indictments. We're not going to incarcerate our way out of all of society's problems. Get into your community, be problem solvers, be collaborators. So we looked at what we felt were important DOJ priorities at the time, everything from terrorism prevention to gang prevention, and certainly the opioid crisis, and decided we wanted to be part of the conversation. And it really has paid huge dividends. We decided to become very, very active in our local coalition. We created a gathering of all the U.S. attorneys, public health officials throughout the state of California. I think it was really the first such convening just on opioids, and realized that we needed more collaboration. We needed more information sharing if we were going to be able to work together to solve the problem. And that really did start, I think, just a cascade of events, everything from supplying the naloxone to the community, to law enforcement officers to ensure that they could engage in saves when they showed up on the scene, to encouraging more drug takebacks within the community, not just on National Takeback Day, but in law enforcement settings. We had our sheriff as somebody who was on the forefront of collecting all year long. And that's become, I think, a standard throughout the state. And we also realized that we could make a difference in terms of treatment and prevention by working together. So we began going into schools together, partnering the U.S. Attorney with people from public health, with people who had suffered losses as a result of the opioid epidemic. And we really did see I think a lot of growth and progress in terms of our ability to work together and to solve problems. And that was particularly true when fentanyl appeared on the scene. And that was a game changer, I think, for all of us in terms of just the number of deaths that we were seeing, the amount of law enforcement attention that needed to be brought to bear. And I think there's a huge need for cross-education. And from that cross-education, what we've seen is that there is greater understanding among law enforcement about what addiction is about, greater understanding on the public health side and the emergency physician side on how they can use law enforcement to improve situations and to get to where the bad drugs are in the community that are killing people. So I think it has made a tremendous difference, and we've seen that you get much better results the more collaboration you have.
Yeah, thank you for that, Cindy. I want to just double back a little bit. Talk a little bit about partnerships aren't easy, and it's very challenging when you have a certain concept of what your role is, and all of a sudden you are asked to do something that seems somewhat counterintuitive. Talk a little bit about any feelings of hesitancy that you heard from your colleagues, or just how you work through that. As an attorney in the U.S. Attorney's Office, how do you help move people to a new perspective on what their role might be in preventing overdose deaths?
That's a great question. And actually, it's as important to find partnerships within your institution as it is to find partnerships outside your institution. And I was fortunate in that while many in the office didn't really understand why we were engaging in outreach and what the point of it was, and didn't have a full sense of exactly what I was doing. And I will say that the U.S. Attorney at that time had decided to devote a full-time assistant U.S. Attorney position to this. And in fact, that grew to 2 AUSAs and a support person. And basically, I found people within the organization who were also, I think, intellectually curious. They could see kind of the big picture, and they could see the results they were getting when they started getting involved. And I was very fortunate to have a prosecutor liaison who worked in basically the OCDF, the Organized Crime Drug Enforcement section, handling the biggest cases against the cartels. And she was also seeing that she was getting better results, and she was able to make a bigger impact by working with the victims, working with the media to do messaging. And so she was able to liaison with me, with her colleagues, and also with agents at Homeland Security Investigations, at DEA, and also with the media. And I think together we were force multipliers. And I would just say that you need to be patient. You need to explain your role to your colleagues, the benefits, and you need to find like-minded people among your colleagues who will help you share that message.
That's very, very useful. I'd like to ask Alyssa the same question. How has your unique professional background helped you to do what you're doing? How, as a physician, do you use partnerships? Do you help convince other people within your practice organization? Do you help work across the community? How, as a physician, get involved in this work beyond the confines of the office that you're in?
I always approached, my job as a physician through a whole person view. Every problem has, social factors that affect the ability to manage a chronic problem, and that addiction is no different than diabetes or hypertension or COPD. And so I always approached use disorder the same as, other chronic medical conditions. And I think that part of that came from my personal background. And then I chose to go to osteopathic school, which the philosophy is very much a whole person, patient centered philosophy, and then also got my MPH at the same time. And then I continued to sort of grow that philosophy at Highland during my residency, seeing so many people with very severe chronic medical conditions that were uncontrolled, really digging into, what are the factors outside of, what medications they're taking that affects their ability to manage their chronic diseases. I fortunately grew up in my professional life grew up in a time where there was a lot more openness for people to treat patients with substance use disorder. And so at Highland, I had the opportunity to work with Andrew Herring and Joan, who was an amazing addiction psychiatrist. And so to really look past the problem at its face, which is that, they just keep wanting medications or taking medications sort of irresponsibly, but look past that and look at what are the reasons, discuss patient in a really patient-centered manner, what their traumas are in the past and how that might be contributing to their actions. And so with that, just also having open conversations with my colleagues about that, did you ask about, why they're using or what the triggers are, because that's really important to understanding more about what keeps them coming back to the hospital for overdose or coming back to get help after overdose, et cetera. And so just like the other speaker said, collaboration within the health center and health clinic is really important, making sure that everyone is using non-judgmental language when they're speaking to patients with use disorder and treating them the same as any other patients who may or may not have use disorder. And so just creating that safe environment and collaborating with, your local pharmacy and your social workers and behavioral health specialists, and making sure that everyone is creating a safe space for these patients. That is, and then also having communication. If anyone sees any red flags or they miss an appointment, always having communication with the physician, social worker, to make sure that everyone is, keeping track of the patient and having their well-being, in the center.
Yeah, and maybe you could talk a little bit about when you're working with other physicians who perhaps aren't as maybe who have grown up within other generations of doing this work. How do you speak with them about becoming partners in this work with you?
Yeah, I think the mindset that many of us were trained in is that we are here to treat the problem. We have the medications. We're going to give you a pill for that problem. But I think what people sort of underestimate is the power of the relationship between a provider and a patient. And so even if a provider is not actively prescribing medications or doing therapy, that just that alliance, that relationship is really important. And also just for that provider to counsel the patient about their use disorder, recommend treatment, is really the best thing that you can do. Even if you don't provide the treatment yourself, knowing where someone can get treatment and recommending them to be treated is really important, because the more and more times someone hears that from the people that they trust, that it becomes, it puts them a little bit closer to that action phase to making some changes.
Yeah, that's very good. So Gary, you've had the experience both at the local level and at the state level. Maybe talk a little bit about how were you able to speak to other people when you were at the state and convince them that they needed to be part of the partnership in trying to address the issue of substance use disorder. So I'm talking about other legislators or community advocates or people that you might have come into contact with within that role.
But yeah, I think you have to start with data. You really need data if you're going to have a movement to improve health. You have to start with really real-time data if you can get it. And then I think you go from there to to awareness of a problem, because there may not be a awareness of the opioid issue totally. And then base it upon science. And then I think the urgency is already there, because people are losing their lives and they're losing their health and their jobs and their homes. And so there's certainly an urgency there around opioids. And then trying to, once you get the buy-in at that point in time, then take action. One thing that I've noticed is that, you know, you need action. Just meeting after meeting after meeting with nothing being done, you're going to lose folks in a hurry, whether it's at the state level or at the local level. But once you get a course of action, you have to actually act and get folks moving in a direction that's going to be meaningful to solve the problem.
Mhm, mhm. So the audience is encouraged to become a part of this conversation by including your questions in your Q&A screen. So we actively want you to to throw some questions at us, and I will do my best to make sure that we have a chance to answer them given the time that we have. Very good question has come from the audience, and I'm gonna go ahead and read this one pretty much verbatim. It's a little on the longish side, but I think it's a very interesting question. I'm interested to hear, what are your opinions about the conversation reallocating criminal justice resources towards things like social services and community health workers that can help with these substance use disorder? So maybe Gary, let's start with you.
Yes, and this is, of course, a politically hot issue, of course, across the country. And I think it's a matter of messaging. And really the messaging could be around, people do want fair, equitable protection from law enforcement agencies. However, we really need to look beyond that and get to prevention. And we need to really look at things that community health workers can bring to the table. How can you prevent problems? And really, how can you train law enforcement to really understand community problems and be a part of that community and earn trust of that community? And so I think certainly I know here in Oklahoma, and working with our local police here, they were very involved and they were very supportive of the efforts to be involved in the community, to understand the community, to listen to the community, and to improve, take some suggestions and really act upon those. And fortunately here we've had a good track record of that happening, and had minimal bad outcomes here in Oakland City.
Thank you. Alyssa, what are you hearing within the community on this topic?
Yeah, it is controversial, and I think a lot of people have their own personal experiences are really dictating what terminology they're using, and their point of view on this issue. I think everyone can agree that people who are should not be killed, and if they are nonviolent, so mental health disorders, substance use disorders, and I don't think that anyone disagrees that there should be a more specialized approach to these people, because the current approach, whether you agree that the police are the people who should respond or not, we just know that it's not working. And so I think that it's varied. I think in Oakland, it is a very different opinion than other parts of the Bay Area, like Berkeley or Albany and El Cerrito. And so, yeah, I can't really say more than that. I think it's very different and very hot topic, as Dr. Cox had said.
Yeah, thank you. Cindy?
I would say from being out in the community, it's clear we have under-resourced communities, and we do need to increase resources to the communities. What budget that comes from, that's beyond my pay grade, but I do think that there are clear distinctions in terms of the resources available in the community. A lot of it, in my experience, boils down to education. There's a huge difference in schools and education across the community, and I think that ends up having an impact on opportunities and criminal behavior. And there are studies that show that if you are not literate, you are 70% more likely to be involved in the criminal justice system if you don't have literacy by a certain age. And so that's been one of our focuses here in our office and our prevention programs. I also think it's incredibly important, and San Diego does an excellent job of this, of partnering law enforcement with mental health professionals, with public health professionals. We have a groundbreaking program here that is the psychiatric evaluation and review team, and they do partner with law enforcement and go out on the tough calls with law enforcement. And I think that that's made a huge difference. We need more of that. So I think these conversations are healthy, and some of the messaging can be misconstrued or not well received, certainly, in terms of where the money comes from. But we do need to increase resources. We need to ensure that public health, we don't have these zip code distinctions, not just with substance abuse, but COVID and other public health crises, the twindemics. And we need to ensure that law enforcement and public health and mental health professionals are collaborating, and that we devote resources to enabling that to happen.
Yeah, really good thoughts from all of you, and I just want to lift up, the what can we find that everyone can agree on as an important priority and an important result. And I think to that question a little bit, we got a very good question from the audience. What are some of the prevention methods that any of you have applied, and where have you seen evidence-based results? And let's start with you, Gary.
Sure. Well, I think an excellent example of a successful program would be the community health use of community health workers. That's evidence-based, and it works. I think also we've had good results from trying to integrate primary care services, public health services, preventive services, and mental health services, so that at the point of contact where they come in to contact with an individual, all three of those are available. And having that more of a holistic, integrated approach, particularly when you have transportation such an issue, there are other issues. While they're there, if you could meet as many of those needs holistically as possible, that has proven to show good results.
That's excellent. Yeah, and I want to know, Cindy, any evidence-based approaches that you have found to be to give you the kind of expected results that you're expecting?
Well, what we found is that DARE doesn't work. Just don't use drugs. Coming from law enforcement, that message we know doesn't work. The evidence doesn't really support that. And so we've engaged in different prevention models. I mean, I think one prevention approach is messaging. Our surveys and information basically show that there is a significant percentage of people that would not take a drug if they knew there was fentanyl in the drug. And so we've engaged in very, very strong and proactive and continued messaging campaigns to let the public know what is out there in the way of fentanyl. And we've also gotten law enforcement involved in helping folks. For example, we have an HSI agent who investigates the fentanyl overdose deaths to try to figure out where the fentanyl is coming from and whether we need to bring charges against the dealer who sells the deadly dose. And he basically was finding people at the scene who were co-users, and he called me and said, how do I get them into treatment? How do I get them naloxone? And I just thought that was a wonderful thing, that we have this hardened federal agent who was worried about getting people naloxone and getting them into treatment. And what we found is that the diversion programs, the steps that you can take to build those bridges between law enforcement and the folks who can get them into treatment, can get people naloxone, take every available opportunity to do that. And once you connect law enforcement with the other resources, you're better able to do that.
Thank you. I want to ask one last question of the panelists. We're getting ready to wrap up here. Any thoughts about how we can implement or how we can integrate people with lived experience more closely into the work that we're doing? Do you have any stories about that? Any experience with that? Anything that you'd like to share with our audience? Let's start with Alyssa.
Yeah, that's really important. I think having people in different stages of recovery meeting really helps people sort of maintain hope for themselves. And so, there are some programs have groups, small groups, where they have different people with in different stages of recovery, and they are pooled out of the group to meet with the clinician one at a time to, for their whatever prescriptions and whatever side effects they might be feeling. But they have that group where they meet week by week with the same group and can share with each other, the challenges and barriers that they experienced that past week or whatever. And I think that's really important. I think initially people are very shy about starting that experience because there is so much stigma around the problem that it's uncommon for people just to be open and start to share right away. But it's really great to have people who are successful to show the new people that there is a way, and that even if they relapse, that there is still hope and they can be successful too.
That's excellent. Cindy?
They have some great programs around the country, and we're trying to get it started here in San Diego, where rather than law enforcement referring somebody in, for example, the person ODs, law enforcement's involved in showing up at the scene of the OD, getting the person medical assistance, rather than law enforcement being the person to try to get the individual into treatment. They basically have peer folks who are certified former folks with substance use disorder are now certified counselors, and they assign every single person to an individual and have that individual follow them over time. And it's a little bit like having a sponsor at AA, but you don't have to show up at an AA meeting to find the sponsor and reach out to the sponsor. This person is assigned to you and is there for you. And they have found that it is evidence-based, is working, and you have a much better chance of bringing somebody into treatment and helping them through relapses and continuing that person in treatment if they're assigned to somebody who understands what that's all about, understands the challenges, and has been there, him or herself.
Well, I think on that note, I want to thank all of you for your participation, your willingness to be on this meeting, and just thank you so much for the work that you're doing and for talking a little bit about the importance of partnerships. So thank you, and goodbye to the audience.